Hello, thanks for choosing our session. It's about new partnerships for public health in Europe. My name is Claudia Habel. I'm from the Austrian National Public Health Institute, the Gesundheit Österreich. I'm Director of International Affairs, and I'm really pleased that you all attend our session. So let me briefly explain why we do this. We are a National Public Health Institute. You will see this abbreviation sometimes, the NPHI. And we joined the International Association of Public Health Institutions, which is called IANPHI, only 3 years ago. But very soon we realized that we are in a very good company with our fellow public health institutions because we face the same questions from our owners or from the society. And we share the same objective, for sure, better health for our citizens. But we understand and understood that we need more partners to pursue these objectives. And that's why we decided to organize this session jointly. I'm very pleased that we also have a younger Steiner, Urska Erklovac from the Slovenian Ministry of Health. She has her baby with her, and I think for you it's a bit of a vacation, you told me, but I'm really pleased you're here. She will monitor the online audience. So for the online audience, please use the chat function to post your question. We will try to take them also in consideration. Also, I have to tell you, but some of you, I know from the faces here, you're quite familiar with Gastein proceedings. There will be Slido polls online. So you just need to go, when I call it up, you go to slido.com, and you see the QR code here. The code is WAVE, as you see from the logo. So please, when I call it up, vote on our questions. For now, I have also now an honor to introduce our president of IANPHI. Unfortunately, he cannot be here. Duncan Selby is president, and he is now chief advisor to the Saudi public health authorities. So it's a really long way to travel here, so he can't attend. Before this, he was working in the public health service for a long time in Scotland and in London for over 40 years. Please have his video statement.
Hello everyone, Duncan Selby, I'm the president of IANPHI. I'm delighted that IANPHI and the Austrian National Institute of Public Health are meeting in Gastein and having this really important debate about how we can strengthen our ability as national public health institutes and how we are working with all the various actors involved in civic society in being better prepared for future threats and in strengthening our resilience when they happen, and in particular about how we address those most vulnerable, we might call them inequalities. And I very much look forward to hearing how the debate develops, the learning that flows from it, and thank everyone for their contributions. I emphasise just how important this is and how good it is to be doing this with our Austrian colleagues.
So thanks to Duncan for these introductory words. But now we go into the session immediately. I will call up the next, our keynote speaker, who is Trygve Ottersen. He's Executive Director at the Division of Health Services in the National Public Health Institute of Norway, called FHI. And he's also Associate Professor at the Department of Community Medicine and Global Health at the University of Oslo. Please.
Thank you very much for the invitation. And it's a quite long trip, but almost like coming home from Norway, this place. I've been asked to provide a little bit of context, and what I will do is, let me see, is to start with a very short story, in case 8 minutes of my monotone voice is too much. This is the key points, really, in 20 seconds. No surprise for someone coming from a National Public Health Institute, we believe we have a central role in health systems. Europe faces profound public health challenges, for sure. That's why we are here in Gastein for this time. New public health partnerships are needed, and I will try to tell why. And then focus a little bit on the dual role that our institutes can play, both as collaborators ourselves in these partnerships, but then also as facilitators, trying to help others to better collaborate. But then there is also always some buts, and we will also come to those. So, institutes like ours can play a central role in health systems. And then we're really thinking about health systems beyond health care systems and the clinical side. Of course, that's an important part of a health system, but institutes like ours play a key role, both supporting the clinical side and really playing on the actors and doing action, of course, outside the healthcare part of the system. And then institutes, I guess most of you are familiar with the National Public Health Institutes, but they are a bit tricky to define because they differ across countries. So here is at least one definition. We are a government agency, and I think that's an important aspect when we talk about partnerships later. And we provide science-based leadership, expertise, and coordination. And to make it a bit more concrete, some of the core functions we often talk about when it comes to public health institutes, and that many, but not all, do provide, is, for example, monitoring of the health of the population, public health research, infectious disease surveillance, preparedness, and response, and also sometimes some more substantial tasks when it comes to NCDs. We also provide, some of us at least, quite a lot of infrastructure services, like registries, lab services, and so forth. So that's at least some of the core functions that NIPHs provide, but not all. Then the challenges in Europe now. It's quite profound, obviously, and it's emerging and changing. And here is just a selection, really. We have the stubborn NCDs, and the risk factors we know all that well. Projections suggest that they will be with us and be a stable problem for many years to come. We have a new focus on infectious disease and the next pandemic and other health crises. We have the #1 challenge of the world, climate change, that of course, as we also discussed here in Gastein, have large health ramifications. We have also an increased awareness now of conflict, also in Europe. And then we have aging, where the needs for healthcare increase, while the workforce, both on the care side and the public health side, decreases. And that's just a selection. But what this shows is really that, of course, the challenges are many and big, but also that they are complex, and it's really intersectoral. An obvious point, I think, for most of us. But that's one of the reasons why we now need new partnerships. We need more actors to work together if we're going to address so complex intersectoral challenges while having quite few resources. So we need to work more efficiently, and we need to combine more competencies. So then we come to one of the roles, of course, of partnerships, so when it comes to NIPHs and partnerships. We are, at least we believe we are, a central side of partnerships. And this is a bit NIPH-centric, of course. We will come back to that. We are in the centrum of this world, and all these actors can help us with our duties. And of course, that's part of the pushback we sometimes get, and part, I think, of also the motivation sometimes now to change prepositions and go from health in all policies to health for all policies. But for illustration, at least, we try to show here some of the many actors that are so important for our work, we believe, but also where we can really help others discharge their responsibilities, and even better, really see this as working together to address some of these complex challenges. And it's not time to go into all of this for sure, but if we go back, I think some of those that at least we at the Norwegian side now is really trying to work much more systematic on. One is on the clinical actors, because so much, we talked about it in a session earlier today, so much during the pandemic, but now also with the NCDs, is really how we can kind of fence off and decrease the pressure on the healthcare side. And then we have issues like antimicrobial resistance, where we really need to collaborate. But there is some tensions there that we might come come back to. On academia, I think the value really, and the reason why I think National Public Health Institutes is such a good idea, is really how it combines having one leg in government and one in science and academia. That's the opportunity, but it's also really a challenge that we might come back to later. Civil society, I think for us, we have so many good experiences also during the pandemic, both how we got input from civil society that improved our decision, but also when we have made a decision to help communicate and implement even quite challenging measures. But to be a bit critical, it's quite patchy how we involve civil society, and it's a lot to do on this to be more systematic. Then we have the more tricky ones, defense and private actors that we might discuss also later. Then the second role, just to mention, because one thing is to collaborate with others, but the second role really that we try now to take more seriously, and that also worked quite well during the pandemic, is to not see us as kind of one end of a bilateral partnership, but really more that we facilitate and create a meeting space for other actors. Like, for example, convening actors during outbreaks, of course, but also now in Norway we try to convene actors working on producing knowledge on mental health, which is really a diverse subset of actors, but where we only do a very small part, but we can really help those actors come together. Then to end with some buts. Of course, I don't know about you. In secondary school, I ended all my assignments. Why couldn't we all be friends, right? And then everything will be solved. Of course, there are some buts and challenges here. I think institutes like ours can be much more proactive in seeking partnerships. Maybe more important, we can be more systematic. I think now it's really, not really, but quite patchy. Some relationships can indeed be tricky. Defense and industry, I think, are two of those. Other actors don't know about us, or they don't think about us, so we have a marketing job to do. Other actors find us hard to understand. We are such a strange combination of very different tasks. What is this big thing there? Or they find us unattractive because they are so slow, old-fashioned, too academic, too little academic, and even annoying sometimes. For example, when it comes to health, everything is health. That's just one thing. So we have some challenges on our side also, kind of marketing us as attractive partners. And finally, of course, we can do a lot, our partners can do a lot, but for some tasks, we really need some help from the ministries when it comes to giving us a mandate and sometimes financing partnerships. Because love is free, but some friends and, and friendships needs financing. So thank you.
Thank you very much, Trygve, also for your open words, and that you also outlined that also the NPHIs have some job to do. But of course, I think I will quote that very often, that love is free, but of course we also need funding and mandates to do our jobs. That's very correct. With that, but we will have a debate on these topics later on. I'm really pleased to go to the next part of our session, which is a 2-minute to talk format. Actually, it's 4 minutes that our speakers will have to talk. They will briefly reflect on past or current partnerships they had with national public health institutions, or what is needed in case there is no such partnerships or cooperations. I call the speakers one by one, and I'm really pleased to start with Professor Annick de Ruyter. She's Associate Professor of Health Law and Policy at the University of Amsterdam in the Netherlands, and is Director and Initiator of the Law Center for Health and Life. She's also board member for Ingolstadt for now 3 years. So please, Annick, take your seat and speak up. And be cautious, it's 4 minutes. And people see the countdown.
Yes, hello everyone. So when I was asked to speak here, I was thinking about my own field, which is European health law mostly, and what can the EU really do to foster this kind of cooperation. And during the pandemic, I spoke to a number of people working in these, because I was doing interviews, in national public health institutes, and what they say is we like the EU so much because that's where we meet people that have a lot of knowledge from other countries. So fostering these kinds of cooperation and also fostering information exchange is really where the EU can have an added benefit. And of course, that's always the question for an EU involvement, is where can the EU have an added benefit above what is already being done in the national states. And if we now look at some of the new laws, laws that have come into existence, you know, in the context of the European Health Union, there you see that for the national public health institutes, there are quite some extra tasks of monitoring, of delivering on pandemic preparedness plans, etc. And I think this is going to be a challenge for the future, where I think we really need to think about, do all the national public health institutes really have the capacity to do this kind of work? Do we have the instruments available? So I know probably some of the richer member states will probably have enough of that going on and have a lot of information gathering, pandemic plans, etc. But what role can the EU play for ensuring that this partnership across national public health institutes is really equal in terms of providing also the capacity to those countries where those public health institutes need it? So I think that's going to be a challenge for the future, because I think in the end, if it's really a partnership, you also want to look for at least comparable capacity to do the work. Yep.
Wow, that was quick. It's because usually we started with a 2-minute to talk format. Gökk is doing this format more often, but usually speakers go far beyond, so I'm quite pleased. But nonetheless, the next one doesn't get more minutes, so I will go. No. So I'm really pleased. He had the longest trip to us. It's Professor Panos Sartoglou from Athens University of Economics and Business, but he also happens to be currently Deputy Minister of Labor in charge of social insurance, and I know his hobby is to talk about inequalities also, and previously he was also chairman of the Greek government's Council of Economic Advisors, or you used to be member of ECOFIN, so he's the one who knows best about money and finances in this room.
First of all, let me thank the organizers for the invitation to this very nice event in such a nice place. Thank you very much. Now, I was asked to elaborate a little more on the question of how can one convince a finance minister to spend more on health. Not an easy task. Let's start. The Minister of Finance in every government is in an unenviable position. He has to face all his colleagues who come there with demands for more spending in their department. And there are good demands. There are not good demands only in the field of health. Minister of Education, we know very well how much human capital matters for the future well-being of the entire country. The Defense Ministry will come there and say, look what happened in Ukraine, we do not want to be next, therefore we need to spend more on defense. People from infrastructure will tell them that, look, with the climate change, the infrastructures that we have need reinforcing, or perhaps we need new infrastructure, and this requires quite a lot of money. Within this framework, we must see, let's say, what a health minister can do. And it is the same as the rest of the ministers as well. And this is something I have not seen not only in the Greek context, but in other countries as well. In most cases, we have ministers of health going there and say how superb it is to have good health in the population. So, and it is indeed. However, you have to prove it. Can you prove it? I think that you can. How can you do that? I know that there are several health economists in the audience. There is this technique that is called cost-benefit analysis. You must have serious cost-benefit analysis there, demonstrating that this particular action is something that will have a very good return in the future. It is not an easy task. And it is not an easy task for many reasons. First of all, several of the actions taken in the field of health, and especially in the field of public health, They have a very long time horizon. Very long time horizon means that the cost will be upfront now, but the benefits will come in many, many years. If the benefits come in many years, it matters a lot what kind of discount rate you are taking. And there is a huge variety there. Therefore, this means that you must have the so-called sensitivity analysis there. And believe me, if you do the proper analysis, you can do it. Proper analysis. Proper analysis now means something that I have seen also from several pressure groups in the field of health using something rather not productively. What I mean, they do not use real numbers. Several of the estimates that I see are what statisticians would call Mickey Mouse numbers rather than hard facts that we have there. And you have a lot of evidence there that we can produce such numbers. Second, there is a question that especially in public health, quite a lot of the benefits are not equally distributed along the income distribution. Several of them go to the bottom of the distribution. There is another technique closely related called social cost-benefit analysis that puts more weight to the bottom of the distribution. Go with an argument there saying that, look, if we do something like this, we do not promote health, we do not promote welfare in general, but we promote welfare for the bottom section of the population, the poorest section of the population. And this is something that is truly important. Now, against all this, there is something that is against your efforts. What did I say before? Most of the interventions that we have in public health have a very long time horizon. However, most probably the finance minister is an elected politician, and the time horizon of an elected politician is far shorter. However, this is life, and we have to live with this. Thank you very much.
Thank you very much. And with this, I will call our last 2-minute talker, can I say so? She's Sabine Kampmüller. She's Managing Director of AFIA. It's a non-profit association for intercultural health promotion in Austria, but she also used to work for Doctors Without Borders. So please.
Thank you. I'm honored to be the representative of civil society here. But I must ask you to keep in mind that I'm only representing a small part of this large universe. That's what we mean by civil society. So NGOs, what are we there for? What could we be good in terms of partnerships? I've been reflecting on this in preparation of today, and there are two things standing out for me. One is, I think many of us are drivers of innovation. Why? Because most NGOs I know are started up because there's someone with an intrinsic motivation to bring a solution to problems that we face and that is not there yet. Plus, our reality is one that is quite dynamic, allows for a lot of flexibility, that obviously also comes with uncertainty, but it makes it easy to try new things and fail sometimes. So that innovation is also what we see that is very much appreciated. And here I come to money and funding. We are funded often for bringing innovative projects. For AFIA, I can say in the last 6 years, we've developed 5 new programs on refugee mental health. So they're always funded because they're innovative. Where we get stuck, and this is my first important message, is when we want to continue doing the successful things, when we want to roll them out, when we want to transfer them to other regions of Austria. And this is super frustrating. As a public health expert, I'm now spending my time setting up private fundraising for AFIA because we need to fill these gaps, and I need to provide some certainty and predictability for my team of now 11 staff members. My second point is that as NGOs, I think we are pretty close to the population. We are we are part of civil society, we are civil society, and we know, or we are our target group. We're talking about crisis. So in the recent pandemic, we could see that people came to us with all these questions, with all their fears, and we were able, my team speaking 8 different languages, to translate information to them, to help them manage some of the fears that were manifold. And we could witness in real time what some of the pandemic containment measures meant to groups in the population. That was the most painful, one of my most painful professional experiences, to be there seeing how some of these things just didn't work. I'm not going into details, refugee families, non-German speaking parents losing their jobs, all these kind of things that you know. And being unable to react. So here comes my plead. When we're talking about partnerships, please give us space to really engage, not only participate, but partake in some of decisions that are to be made. Because really, I think many of us can connect and do connect to different groups in the society. And at least that's my vision for better health, for health promotion, for this to be a joint action.
Thank you very much, Sabine, and to all panelists. I think we heard your voices, and especially Sabine's plea to have continuity with all the programs. I think this is debated all the time. I'm working in the field of healthcare for more than 25 years, and I think we need to do better, that this demand has not to be posted again in the next 20 Gastein forums, because I hear that everywhere, and nobody left us out initiatives and everywhere. That's true. We need to get better in these regular funding schemes. With this, I think it's now time for the first sliders, also for our online audience, which I hope is huge. At least we try to motivate national public health institution members from our big network of IANPHI that they should at least attend online. Because for them was, it's driven by the US office also. They were asking, Bad Hofgastein, where is this place? For them, it's a really tiny spot on the global map. But still, I'm hoping that many are online attending. So with this, can we go to the first slide, please? Julia, launch it. It's about what is the most important enabler to have closer cooperation between the national public health institutions and other institutions. Please rank it, and don't forget it's WAVE. In the meantime, when you hopefully all take your phones and vote, my panelists don't have their mobiles with them, so the rest you have to engage really heavily. I'll ask Urska, is there anything already in the chats or from the online community?
Yes. I would just read out the questions we have received so far. The first question is from Luke Nicholas, and he's asking, we need to quickly upgrade skills and profiles in order to be able to use the new tools and methodologies which are becoming available, having, of course, the use of AI in mind. Are there sustainable initiatives to sustain this goal? Then I have a question from Berta Mitze. She's saying and asking, the EU has a better regulation toolbox that essentially tries to standardize and mandate the use of cost-benefit analysis. Do you think this could be introduced at member state level, for example, requiring similar cost-benefit analysis across government departments? And one last short one. What can academia and NPHIs, the National Public Health Institutes, learn from each other in terms of scientific practices? And just maybe in case if you have extra time, with respect to barriers to effective partnerships, are there any elephants in the room, meaning underlying tensions or unspoken issues? And that would be all for now.
Wow, that's many. I think I hope I could take note on all of that. Especially the last one is also the elephants in the room is always also a topic we have in Gastein every time. But still, it's a very important one. And before we have the results of the slide, or perhaps I can ask Trygve already. Do you see any elephants in the room on unspoken issues and partnerships, also in your country or in Europe? He's the chair of our regional network in Europe, so perhaps you can report from this.
Yeah. If it's elephants, I don't know. But of course, there are tensions between NPHIs and some of these actors, or not as a general rule and across all actors, but that there can be. And I think some of the collaboration with the healthcare providers and clinicians could be better, increased understanding between those two actors. I think also when it comes to academia, I mentioned it earlier, we experienced that sometimes academia see us as too little academic, too much like I'm exaggerating, but the kind of brain death workers, you know, but even worse in a way, dealing with, you know, handling very concrete issues. And that's an important, if not an elephant, something to work on, because that's, as I tried to say earlier, that's where I think one of the best things about NPHIs is really there. That we have one side towards science and academia and the other towards policy and government. It's only some few sectors, at least in Norway, that have that kind of institutes, have that kind of organizations. And the beauty, the value is really there. So we need to work on that tension in some sense being productive rather than not collaborating for actually misguided reasons. And the second tension there actually is, and I think that also applies for some other NPHIs, at least us that do a lot of data collection, I think some of the tension is that big thing there in the capital is asking for a lot of data, collecting it, and we never see it. Or they do funny research themselves on it. So we have a lot of work to do when it comes to really sharing data and also work together on both improving the story, which is partly right, partly false, and then also improve on the actual situation on the ground. So that's just 2 or 3 examples of, if not elephants, at least some tensions.
Thank you so much, Trygve, for sharing this. And I had to smile when you mentioned the big hole somewhere, because also we as Public Health Institute, we also claim to have tons of data, which we partly have but partly don't. And it's always, I realized that most public health institutions are in the capital cities, and they have always the regions. When I talk to regional countries, they always think of, oh, well, whatever they do in their capitals, it's had nothing to do with us. And we don't know what they need it for, and why do they need this regional information. And this is such a shame, because I think we all have the same objectives in the regions, in the central capitals of Europe. As I said, we would like to have better health, and all the calls for a joint health union. If we cannot even handle this in our own countries, you know, to have a coordinated approach, how can we handle this in Europe? So, but I'll go now to the Slido. I think it's closed. So what are project-based cooperations? We have at least 75 respondents, which is good. So what is the most important enabler is a project-based cooperation. I could agree to that, because then you know people like face-to-face, now after Corona even. Again, it's working well, as we see here. And I think I could hope Gastein could be, as it was very often, let's say the seed could be sown for one of such cooperations between the public health institutions and the other sectors. With that, I will. There was another question I learned about this better regulation toolbox on cost-benefit analysis. I'm honest with you. I'm an economist myself. I read this. I attended some of these information sessions for this toolbox. It's really complex. I'm not sure. Just a hands up. Who has heard about the better regulation toolbox so far? At least few. Perhaps I will come to you for some comments on this. But Panos, for the moment, have you seen this toolbox also, and what it will help us if we apply it in all the countries?
First of all, let me combine 2 questions that were there. Cost-benefit analysis techniques for the evaluation of private projects exist for a very long time now. Formally, they were introduced last century, at the beginning of the century and so on. The discussion of using it in public projects in a formal way, it was developed in late 70s, early 80s and so on. Several governments have adopted projects like them. And definitely, according to the question that was asked there, this is something that applies not only to health, it applies to education, it applies to infrastructure, it applies to everything. However, in the public sphere, we have a very important kind of a question. How do you quantify an improvement in some areas? Just to give you a couple of examples. We built a particular bridge that is connecting an isolated area with the rest of the country. Financially, it is not a good idea. However, it has a very big regional impact. How do you quantify that? Therefore, you need the social cost-benefit analysis that I mentioned before. We introduce, let's say, this legislation for driving safely in the roads, and as a result, we save that many lives per year. How do you quantify that? In the case of health that you mentioned there, we adopt this set of policies and we extend expected life expectancy, let's say, by 3 months. How exactly do you evaluate them? There are techniques for all these things. And this is the reason that I mentioned you must have all this sensitivity analysis to tell them that in the end of the day, whatever you adopt there, this is a good investment. Now, there was also another question that was hinging upon... sorry, before I go there. There was something else that I forgot mentioning before. Cost-benefit analysis is not something you must apply only to your future projects. You need to do evaluations in your current projects as well. This is a lesson we learned damn well in Greece during the period of the crisis, and especially in the area of public health. There was quite a lot of fat around. Therefore, the first thing that the Ministry of Finance will ask you is, okay, but you received so much money. Are you sure they are well spent? If you have an answer there saying that, yes, I did this evaluation, that evaluation, I improved this and that, you strengthen your argument quite considerably. Finally, to go to the first question, all these things we are talking about must be put in a growth context. If all these actions we are taking retard growth, okay, sometimes there are arguments for retarding growth and have a better distributional outcome, but there are relatively few cases and it's very difficult to defend them politically. Therefore, for all these answers, we must have in mind the growth prospects that these measures will introduce.
Well, I understand what you want to say with the cost-benefit analysis, but I'm a bit provocative now, but I do that. I have the feeling still, then we provide a lot of evidence. You know, public health institutions are our main job, you know, to provide evidence, always in a very nice way. We are now, you know, requested, nobody will read our 200-page reports anymore, and not even the 10-page short versions or executive summaries. So it's a 2-pager, and it should be really easily to understand and convincing, you know. But still I have the feeling, now we provided a lot of evidence over all the years. Is it really helpful? Does decisions follow this rationale? Or is it more that we as public health institutions failed to work the emotional side of things, of decision-making? What would you say?
Let me... Now, this is Panos the technocrat rather than Panos the politician. Definitely you need to do that. How the government in general, or how the finance ministry will respond to this, this is a different type of question. Usually, people who are in the Ministry of Finance will ask you this kind of evidence. And what I have seen time and again, not only in Greece, in other countries as well, the main appeal of health ministers to be emotional rather than quantitative, as I mentioned before. Of course, you can combine the two. You can say that, look, I have this evidence there, but this is something that improves the standard of living of the entire society. Put it in, you know, several of you may be familiar with the capabilities approach of Amartya Sen. In the end of the day, health is one of the so-called basic commodities. This is something a right for every citizen in a civilized society. Put it like this. But of course, this argument cannot be done for all aspects of health spending, only for some of them.
Yes. Nick, please, and then Trygve, join in.
Yes, I think this also goes more generally to lawmaking. There's a lot of, especially people in the sciences and even in academia, they feel like lawmaking should be something that is based on actual knowledge, actual science and facts. That is, of course, true, and I agree. But also, there's always a need for a balance and a value argument and ethics and cultural differences, etc. And you always need to make choices, and that's always a matter of normativity and politics. And so I don't think you can ever take that out of lawmaking, nor should we want to. So this idea of evidence-based lawmaking or evidence-based rulemaking, yes, but in the end, you need to make a choice, and it's always political, and it always has to do with values. So I think that's a very important takeaway, and I think you agree with me.
I fully agree with this, and all these things must have some principles in the end of the day. This is why I refer, let's say, to these basic commodities and the like.
Please, Trygve.
Thank you. 3 points about the Mickey Mouse numbers. So first, and the maybe least important, but discounting rates. The problem, I think, for many of our working on public health is that people discount future benefits quite a lot, and even more than they say they want in calm moments, or if we did a Slido now. So that's just a challenge we have as a community, and hard to criticize entire humanity in a way for that. But at the same time, in my previous life, I worked with public health ethics, and of course, one of the projects we had that was actually to look at the discount rate, and from that perspective, it's really a Mickey Mouse number, the discount rates we use. That sometimes it's just tied to the same we use on the cost side and so forth. So that's a choice. We can make a choice when doing those analyses to what extent we will discount future health benefits. And that affects a lot what, obviously, the cost-benefit ratio of different interventions, because they differ when the interventions come. Second, in our institute, we tried to put up a team of economists during the pandemic to do exactly cost-benefit analysis. They did that quite well. We were better at look at proportionality and so forth on measures. But then we got the same pushback from the Minister of Finance and others. We need more cost-benefit analysis on the preventive measures and now preparedness and so forth. And I totally understand that. Went to my team, said we need that, and then they actually protested and say we can of course do that analysis, but it will be Mickey Mouse analysis or numbers that we put in. So on that second point, I think I'm among those that think we have a big job, great potential in this space. We do too little to show the evidence we actually have, because we kind of take it for granted when we sit inside. So I really think as public health institutes, we should work together in this field. But the third point is actually, don't forget that if we don't have good primary studies on the effect side of some of those interventions, it will again be Mickey Mouse numbers. And there we have at least as large a job to do as communities and as public health institutes. Again, very easy to see during the pandemic, quite a lot of clinical research. What about the amount of rigorous experimental research on public non-pharmaceutical interventions or public health and social measures? Extremely small. So that's we need to work on those two in parallel: primary research and cost-benefit analysis.
Anik, I'm sure you would like to respond to that.
Yeah, I was just thinking a little bit more about the outcome of the Slido, where it says people were saying, we need projects. If we do projects together, that way you get to know each other, and that fosters cooperation. And then all the way underneath, it said European initiatives. But I think those two can be the same. So I think the EU could be fostering these kinds of partnership through the projects, through research projects, which then brings me to a second point with the relationship with academia. I think, the kind of data that is being created in the National Public Health Institutes, I think that makes you incredibly interesting to academia. So if I was to make a marketing plan of, ensuring larger capacity in your research that you can do, it's sharing that data and working on that data together for publications, because I know that academics like that stuff. As you do.
But this could be a role then also for the NGOs in future, that they are like our labs in the outside, when you do, because I understand what you say, Sabine, that you are quite innovative, you have good new ideas, but would you need support or more cooperation to establish also scientific standards? Because it's like that, if you have then evidence, and there's sometimes little publications from the things that are done. So how you could team up with some students perhaps, and we could be matchmakers together with university. Would this be helpful for you, for instance?
For AFI, actually, this is what we do. We had our first evaluation studies done in cooperation with others or forced by the National Public Health Institute, which was very beneficial in that case. Yes, we could do with more, especially research cooperations. My take on the choice would be a bit beyond the project level, but work on themes and challenges together. And here I can mention a very good experience we are currently having with the Austrian National Public Health Institute. There's an expert group in our specific field of refugee mental health that has really gained momentum during the crisis. Mm-hmm. Super useful to have updated information, both ways exchange. And we managed to come up with a concept policy paper that I think is really of mutual benefit now. What I want to say here, and maybe that's a bit of an elephant, that works if we can feel it works when there is a government behind that is favorable of civil society, NGO cooperation. So I just wonder whether these are things that could be anchored a little bit more so that they survive beyond a next, maybe less favorable government.
I think this is I think you refer to the institutionalization of, let's say, also civil engagement in some of the things. You know, there's documents like the European Beating Cancer Plan, which, you know, is one, the cancer mission, is very high on the agenda right now. And this is one chapter there explicitly where it's mentioned not only the cooperation of patients, but also of the whole civil society, so of all the citizens. And I think this is as good as we can have as documents, I think, yeah. Because to put it in the law, it could be also a backside, because then if it's, you know, it could avoid decisions, because then there could be conflicting interests, and it's, to my understanding, bureaucratic organizations often then just do not decide, you know. So they don't have to decide to go left or right, but there's a standstill. So this Beating Cancer Plan model, I think, is a good example. But I'm now looking into the audience here, and then we can also have a look online. Is there any questions or comments from your end? Please, feel free. Please, can we have a microphone? Please always stand up. It's behind the sir, and then Roberta, please. Always stand up, introduce briefly yourself, also for the online audience.
Oh, thank you very much. My name is Ricardo. I'm the president of the Unite Parliamentarians Network for Global Health. So it's a network of current and former policymakers in more than 100 countries. And it's very interesting to hear the conversation. I agree with most of what was said in terms of how to convince your ministers of finance or heads of government. And I would say that leaving those situations in which those that actually have the power to make decisions in health, having the political power to make those decisions in a cabinet, considering those an exception, all of the other situations, which is the majority, normally the people in health don't have that power in the cabinet. And from my experience, what we have seen is that to convince the ministers of finance, there are a few things we need to take into consideration. One is raising awareness. The constituents have to have a voice. If we're trying to push for something that people don't know about, it's very difficult to get the Prime Minister or the Minister of Finance on board. So that awareness from a public level, that support coming from the grassroots, I would say is critical. Second, the cost benefit is only useful if we're able to show where the money is coming from, because there's an initial investment that is needed. We can talk about long-term cost benefit, but at the end of the day, we need to show in the immediate budget where that money is coming out. So when we present an idea, we should have a key in hand solution. And the third comment that I would leave is, there's something sometimes we don't talk enough about, which is cost opportunity. So we always say, what would be great if we did something? But not doing anything is also a political choice. That also has a health impact. And discussing that option, I think, can sometimes put pressure in the right direction, making sure that we are moving towards better health outcomes. And, well, out of my experience, these are some ideas that hopefully can help move the science towards better policy making. Thank you.
Ricardo, thank you very much for that. Next, Martin, please. And then, please, yes.
Thanks. Maybe it's a difficult question, but if we look at history, public health hasn't always been on the side of the angels. And certainly in this continent, 100 years ago, many public health institutes actually were complicit in some of the worst things that could have happened. Now, I don't want to draw an analogy with that, but I want to look at the issue where, as a government body and as civil servants, you are working with a government that is pursuing policies that is actively damaging health. I live in a country where that is the case. We've had tens of thousands of avoidable deaths because of the austerity and the other policies. And yet our public health community, the formal community, has been almost silent in all of that, and to many of us means it's completely squandered any credibility. That's a really difficult one because you can work behind the scenes. If you speak out, you may only do so in your memoirs. That's been an issue in Ireland, actually, in the last week or so, where you have this tension. We have a piece coming out in the BMJ in the next day or two talking about an I Spartacus moment where we argue that the public health medics, for reasons that you will explain there in the UK, actually do need to speak collectively about some of the things. But I'll be interested in reflections from all of you as to the tensions that are faced. Maybe you don't work in a government in a country where this is a problem, but other people do work where this is a problem.
Thank you, Martin. Perhaps somebody would like to reply to Martin already? I know that in many countries, the public health institutions or the public health services are under debate or under change. Also, like in Norway, or you would? Yes. Panos, please, and then the others.
Let me have two remarks. First of all, regarding the first comment that was mentioned there. Yes, it is very nice to mobilize grassroots, to have public pressure and so on. Usually, the people who exercise most of the pressure are not the grassroots, are the people who have the money. They are the industry. They press for more pressure, for more spending on health. However, whether this extra spending is well spent or not is something that is open to discussion. Regarding your question, you are absolutely right, and cost-benefit analysis does play a very important role even in this case. It is a political cost-benefit analysis there, but it has a direct repercussion in this one. It is true that there were several avoidable deaths because of the recession that existed in a country, especially like mine. You cannot imagine how many more avoidable deaths would have been if instead of the recession we had an unruly default of the country. And the government has to take all these things into account. Therefore, there was this recession there, but what would be the alternative that we have done there? And this was something that we tried with all range of governments in place. Thanks.
Thank you. Trygve, and then perhaps Anik.
You might be right that, of course, countries are very different here. But two or three reflections. One is, I mentioned several times that what intrigues me about public health institutes, both as an idea and a place to work, is really that we both have a government side and a scientific side. But of course, as you more than alludes to, if the science side is not independent, it's not worth much. So I think one of the important things, preferably in law, is to safeguard the scientific independence of national public health institutes. And that means in most cases that, of course, you get your money and your tasks from the government in most cases, but you are free to choose your approach to that question, and you are free to communicate the answer when you want. So I think that's the ideal. Even in Norway, of course, we disagree with our ministry. So during the pandemic, that was solved in a way that we wrote written recommendations to the ministry. It was all made transparent some hours before the decision. So in the moment the decision came, they could also see what we have suggested and discuss the discrepancy. During the pandemic, we did also something that is, I think, it's more uncommon and is worth a discussion in itself. And that is, to what extent is this agreement good, bad, neutral, or we just is better than alternatives? So 2 examples. We several times had the disagreement between the 2 main advising institutions in Norway. Again, that surfaced in the moment that these documents came up. We even had disagreements within our institute because we tried to be an academic institution. So then we let researchers actually come out and speak against others in the institute or even us as a leadership group. So in the most extreme case, 2 different people from our institute debated each other on the national television during COVID. Of course, that requires certain baseline trust and so forth. But at least I think in Norway, and you can hear other analysis of that, but I think in Norway it actually worked in that way, that trust increased, or people understood that, of course, there's real debate. These are difficult topics, and we don't put the lid on it. So just, maybe I'm picturing, of course, the context differs, but that's at least one approach and one ideal that we try to keep on.
Thanks for sharing. First Annick, then we take another Slido, and then we come back to Beate's question.
I think also it's very important. Is this on? Yeah? I like that. I also think it's very important that the nature of science is uncertainty. So you want to be very transparent about that and not put out this idea to society that you know it all, right? So there's this humbleness that you need to have in terms of what you're putting out. And I very much like the approach that you took to put that out there and make that very transparent. And then the political side comes in, okay, now you have to make choices given that uncertainty in science. And so I would say, to what you were saying, I don't know that you should put people in that position to take on the politics. So I'm not sure if I would agree with your op-ed or your BMJ piece that's coming out. And the other thing I think that's very important, and I think it was the philosopher Jaspers that said this, that the real test of health is when you're not so concerned about it, right? So when you're not so busy with your body or your health or if you're eating right, etc., because things are generally in harmony, you're generally feeling okay and you're going about living. And I think that goes for society too, is that there are other things and there's choices to be made. To what extent we're putting all of our efforts into being healthy and living longer, because there's really, ideally, there's more to life than that. And so that is also for us in the health community. I mean, obviously, I care a lot about health, but there is also a little bit of humbleness in that there are other things that make life worth it.
Thank you so much. And with this, I would like to have the second Slido online, also for our online community and for you in the audience to engage. The question is about enablers from a perspective of a partner and the barriers, actually. As a prospective partner or current partner, what are the barriers forming effective partnerships with public health institutions? Please tick all those which apply. And in the meantime, before we have the results, can you have a microphone for Beate, please? Hear the question here. And then Michelle in the back, yes.
Just in short,
please stand up and introduce yourself.
Just in short, I'm referring to the discussion of evidence do we need and about data. And we had, during the pandemic, the really very first time that we had good evidence of mental health of the youth. Because we have a lot of really good scientific studies about this, which as a professor of psychology, I really like this very much. It was paid attention to it, to the kids and to the mental health. And we got, as an association of psychologists, a lot of money to support. We had very good evidence that it really helped. And now we got more and more money because there's evidence. So I really want also to say, so as a scientist, yes, science is, especially if we're talking about mental health. So the soul we do know is really a dark continent and very hard to really to measure. But if we try and do it good, then it helps. So I think it's good to make good evidence, and we should try. And also I would like the community of public health more to please pay also more attention to mental health.
Thank you, Beate. I think it's very encouraging what you say to a lot of people in this room. Then I go in the back, Michele, please, and then Andrea, and then we have the Slido results. Can you please give the mic to Michele? Yeah, you have it. Please.
Yeah, I have it. Yes, morning, everyone. Usman Khan, I'm former director of the European Patients Forum and now visiting professor at KU Leuven in health policy and management, but doing most of my work in London. And I just wanted to actually build on the point that Martin made. When you're talking about partnerships, you very much focus naturally, I think, on institutional partnerships. But what has been noticeable in London recently, and I give the examples of ULEZ, which has been a tariff on being able to drive high-polluting cars in London, also in terms of some of the proposals around taxes on unhealthy foods, that what we've failed to do is to be able to form a partnership with the people who pay, the individuals who pay for the public benefits. So there's the private cost for the public health benefit. And if we don't engage, you can see, I mean, with ULEZ, there was a real sort of Brexit moment where there was an electoral pushback against a public health measure, a rejection of a public health measure because of the perceived or actual disbenefit in terms of their own personal financial situation. So I think I would just say it's been very interesting, the discussion, but I think we miss the public at the public part of public health. We must include that as well.
Thank you. Please, Andrea. The next in the second row, please, Andrea. And please up and introduce yourself.
Yeah, thank you very much. It's an excellent session. My name is Andrea Schmidt. I'm the head of the Competence Center of Climate and Health at the Austrian National Public Health Institute. The International Association of National Public Health Institutes produced a paper not so long ago about the role of public health institutes in the context of climate change. And they talk about three different areas. One is about monitoring and evaluation. You mentioned that already. One is about responding and facilitating action. You also mentioned that. And the third one is about protecting, promoting, and educating, and it includes advocacy. And I wanted to ask, especially when you think about climate change and how also public health institute can act in that context to get the health system to mitigate climate change and respond to climate change, and in general, to bring new topics also on the table towards ministries or also the international community. I wanted to ask what are your experiences and how far can and should public health institutes take on that advocacy role also in promoting new topics and be also a little bit political maybe. Thank you.
Thank you, Andrea. So Trygve, this is again a question for you, I would say. Well, as our chair.
It's a really important and a bit troubling question because, at least for my institute, because in some sense on other areas I feel that we have things to showcase. This is a case where we struggle with my last point, mandate and financing. So I think everyone in the Institute now agree that this is #1 challenge. And we also have to your last bit of the question, we also have the room for sure, I will say in Norway, to point to the negative health benefits of different policies, even though it's politically sensitive, as we do when it comes to alcohol and gas and other politically sensitive issues. So that's not a problem. For us, it's actually a problem simply to have the mandate and the resources to go there. So we are kind of struggling. It's more we say almost every day a bit painful actually that we don't do more. But to go beyond my own institute, I think this is an obvious room. This is a place where we really should be. Really, we have the natural mandate to really be the one that shows the negative health benefits in short run, long run. So that's easy. But to take that role, that's I think a struggle for many of us the next years.
Sabine, please, and then we have the Slido results.
Yeah, here I'd like to draw on my previous experience with Médecins Sans Frontières, where advocacy was such an important part of our work, as still is, of course. And I think here we really need transnational alliances, global alliances. Fantastic to have the European and international associations, because that cannot be solved on national level. It needs a global voice, really. And I was super happy to see on the last Friday for Future that there is Health for Future already. So maybe we should all join them.
Thank you. With that, can I have please the Slido, the results of our last Slido? Yes? Okay, so the main barriers are lack of resources, funding, and staff time, followed by a lack of information about the benefits of the partnership. Okay, the second point I think is easier to be addressed by all of us, and I think Martin said it also, it's, or Ricardo has left, it's the public pressure, it's needed, pressure from the communities and pressures from ourselves. If we need a mandate, a formal mandate, it's also questionable. I think the Finnish public health director recently said to me, he is asking all his department heads what they can do for planetary health. And some of them were really surprised, he told me, but still it made them think, and they had a nice debate in the THL on this. So this is, I think, as public health institutions, we have, of course, we are allowed to do some pre-thinking, even if we have no mandate so far, perhaps. And for those of us who have one, I think we can really go into these advocacy roles. So for the moment, I'm almost done. It's so nice to have this debate here, but still we have to be closing slowly. And with this, I will hand over to Quentin Sandifer, who is here from IANPHI. He's a strategic advisor to IANPHI. He was, until 2020, Executive Director of Public Health Wales, and he was the first chair of the IANPHI's European network. So please, can I have perhaps your key learnings from this session?
Well, I've got the hardest job, I would suggest, to try and make sense and distill out some of the key messages. So I'm going to approach this very briefly in a stepwise way. And just, first of all, let's pause and ask ourselves, what are the benefits? Why is it important, do we believe? I'm just going to suggest that we do believe this. Why is it important that we do work in partnership? So fundamentally, what is it that partnerships afford as a benefit? Well, we've heard some of that today. We learn from one another. We're able to exchange information. We're able to solve problems together, or at least to gain a shared understanding where there are differences. And perhaps not said so clearly today is we're actually able to lean on each other's strengths. And I would suggest that is an important additional facet of the benefit. So we've heard quite a lot about the different types of partnerships, and we've noted the importance of science underpinning the role of a national public health institute. IANPHI often says that it is important for institutes to be independent on science, but not independent of government. We cannot necessarily remove ourselves from the policy/governmental space. For one, many institutes are placed in that situation. That is where they operate. And even if they don't, they're sponsored by government. And even if they could argue, which I would suggest they can't, or I can't think of an institute that might do so, they at least derive funding to enable them to function. So if you can't be independent of government, what can you be independent on? And the answer has to be on science and evidence. And I think part of the challenge that public health institutes have faced is that they've not been able to successfully communicate that distinction to the wider community, to their institutional partners, but also to civil society, the public, if you like, at large. And I think this was exposed very starkly in many countries during the COVID pandemic. I was involved in a survey of our National Public Health Institute membership in 2022, in the wake, therefore, of the pandemic. And one of the key things that came up repeatedly was that public health institutes were simply spokespersons for government. Now, that may be true in some places. It may be actually a reflection of people's frustrations, and it provides an explanation for them for many of the things that didn't go right. But unfortunately, for many institutes who truly attempted to speak authoritatively and independently, they were unable to make that voice heard more broadly. So let's turn the whole thing around and look at it from the opposite end of the telescope, if you like. So my question in reverse is, who are civil society? Who are the constituents that a public health institute is attempting to communicate with? Because within our civil society are themselves institutional entities, and those institutional entities may not themselves necessarily represent the voice of the wider community. And I do think it's true that one of the problems of national public health institutes is that they've not necessarily found a way of successfully engaging with the true voice of the public, the people in the community. There are many attempts, but inevitably we often do it indirectly through representative groups in civil society. We often also say, well, we speak for the public's interest through advocacy, but even then, I am sure that, as has been suggested, our voice on advocacy has not necessarily been heard. So I'm just going to wrap up very briefly, because I know Claudia, I've learned from engaging with Claudia for 8 months, you have to do what you're told. So I will wrap up very, very briefly and just make a couple of simple statements. What do we mean by science? And I think part of the problem for us in public health institutes is that we have defined science in biomedical and social terms. And I think what we need to do is recognize that the scientific approach is a scientific, in inverted commas, which embraces a wide range of other sources of knowledge. Point one. The second is, how do we engage with civil society? I don't have a simple answer to that, but we really do need to find the mechanism that enables a public health institute to truly engage, as Sabine said, and truly engage as partners, and therefore embrace true joint action. I think it's something we really need to think long and hard about, is how we continue to play that almost unique role of spanning both government and science, academia or otherwise, in the way that Trygve talked about. And finally, I like what has been said about economic analysis. But this is not a new discussion. We've been talking about economics for 2 or 3 decades. And I'm not convinced that we've ever really resolved the tensions that have been exposed even in this discussion here and which are evident when it comes to truly making investment decisions. Thank you.
Thank you very much, Quentin, for doing this hard job. You're totally right. This is the thing which is the hardest to take home messages for you. I hope you learned that we are really interested seriously in new partnerships, trying to be matchmakers. We are still here. Also, our executive director, Herwig, is here. Address us, if me or Trygve also, if you're really interested in such partnerships. If it's project-based or on a personal basis, we are here for you. And thanks for joining us, and thanks for Gastein for the excellent organization. Yeah.